I'm Paul Melmeyer. I am Vice President of Public Policy and Advocacy here at MDA. And I just wanted to spend a few moments with you this afternoon telling you about our ongoing effort to obtain ICD-10 codes for the limb-girdle muscular dystrophies. This has been going on for almost 2 years now, and we are actually have a lot of exciting things to share about updates on this project. So let me just first start with a little bit of a background on what ICD-10 codes are, because for many, ICD-10 codes aren't necessarily something that you give a lot of thought on, that you think all that much about. So perhaps it's a new term altogether for you, for that matter. But what ICD-10 codes are, and just to spell out what that acronym is the International Classification of Diseases, and this is the 10th version of this. ICD-10 codes are the diagnostic codes that are entered into medical records that then allow for essentially tracking of individuals with these diseases. It facilitates epidemiological research, also leads to better care and reimbursement, and a number of other things which I'll get into in a second. Essentially, these are just used for the medical claims of reporting in all healthcare settings, and are they facilitate the determination of what care should actually be offered to an individual with a specific diagnostic code, and allows for that conversation, that deliberation to happen in a more precise manner. So these ICD-10 codes, while they're very complex, they're esoteric, they happen behind the scenes. If you're an individual living with Lgmd, they actually are quite impactful in facilitating care, as it allows for a more precise diagnosis to be entered into the record. So as I was getting at, why are ICD-10 codes important? Well, to start, as I just said, they lead to more accurate and precise care. If an individual does not have a ICD-10 code that is specific to their disease, they do have an ICD-10 code. Essentially, everybody does, as they're being diagnosed with whatever disease or condition or medical situation they happen to be in. But for those who don't have a specific code that is specific to their disease, they're oftentimes diagnosed. A diagnostic code is used that is much more general, and that doesn't perhaps actually particularly accurately capture the situation that the individual is experiencing. So to have an Lgmd ICD-10 code rather than what you'll see here in a second, which is the current situation, the other muscular dystrophy diagnostic code within the medical record, already that will allow for, within the clinical setting, within the medical setting, more precise care, more precise and more accurate care to be offered. Also, this facilitates enhanced disease surveillance and data collection. There are many researchers out there, both in public health as well as in other specialties, who wish to research Lgmd, not in the sense of kind of the biomedical research, but in the sense of how many people have Lgmd, where are they located, what care centers do they happen to be going to, what age were they diagnosed, what is the progression of their symptoms, as can be tracked within medical claims and medical records. All of these things can be researched and can be looked at a population level, and lessons can be drawn from these data. But as you can imagine, if there is not a precise code being used, and in the case of Lgmd, the other muscular dystrophies code is instead being used, researchers wanting to track all of these different things that can be researched, they can't really do so with Lgmd using ICD-10 codes, because there just isn't an Lgmd ICD-10 code. And then finally, better coverage and reimbursement for Lgmd treatments and care. Right now, as insurers are considering whether they should be covering any specific treatment. It could be a drug, could be a medical approach, could be some of the devices, for example, that we were just talking about in our previous presentation. They will look to the medical record to see what is the actual diagnosis of this individual, and is the device, is the drug, is the medical procedure, is it standard of care, and is it medically necessary? And again, if they see a device or a drug or a treatment that it is indeed medically necessary for an individual with Lgmd, but they, in the medical record, see that the diagnostic ICD-10 code that's being used is actually other muscular dystrophy, that doesn't give them a whole lot of confidence that the treatments or the therapy or the device that is being sought for reimbursement for is actually specifically appropriate for Lgmd or for the individual with Lgmd. And so consequently, without these ICD-10 codes that are specific to the disease, these ambiguities can lead to delay in accessing care, as insurers are going to want more information. They might want prior authorization. They might want additional information from the clinician or from the prescriber. And it just can cause lots of problems and lots of headaches that just are unnecessary entirely. So as I've been alluding to, this is the current ICD-10 code structure for muscular dystrophies. And if a coder, in most of medical settings, there's of course the clinician, the medical professional, but then also within the setting, they oftentimes have a coder that translates the medical record into the system and then assigns ICD-10 codes based upon what the clinician or the medical professional happened to write down. And this is what they see essentially within the system. They see that there is a general category of primary disorders of muscles, and of course within there is muscular dystrophy. And then there are some specific muscular dystrophies who have already obtained ICD-10 codes. Duchenne and Becker muscular dystrophy have their own at G7101. FSHD has theirs at G7102, and this was actually due to an effort that was led by the Duchenne and FSHD and Becker community back in 2018, I believe it was, when they also did not have an ICD-10 code that was specific to their disease, and so they successfully applied and obtained ICD-10 codes specific to Duchenne, Becker, and FSHD. But as you can see from there, everybody else essentially within the muscular dystrophy category are lumped in the other specified muscular dystrophies code. That's of course limb-girdle, as you see highlighted, but that's also distal muscular dystrophy, congenital muscular dystrophy, ocular muscular dystrophy, and these, as you know, are different diseases, different experiences, different progressions, different symptoms, different lots of things, and yet they're all assigned still the same ICD-10 code. So as thinking back to the last slide, if you're an insurer wanting to know, is that treatment actually right for this individual? If you are a researcher wanting to do some epidemiological research on one of these, if you're a clinician or if you're a medical professional and you see in the medical record that this individual has an other specified muscular dystrophy, well, that doesn't really tell you a lot. So consequently, because of this very situation you see in front of you, what we did was we knew that this was a problem, and we heard from the community, we heard from biotechs, we heard from others that this was a problem within the Lgmd space. And so we, knowing that doing things together with community organizations and not in any way kind of in a siloed manner, we knew that we needed to solve this problem. So what we did was back in the fall, actually the late summer of 2020, we gathered these groups that you see in front of you here. So we invited Coalition to Cure Calpain 3, Jane Foundation, Speak Foundation, other specific, the 2I groups, as you can see here, and other groups together, and deliberated with them on what can we do about this. And it wasn't just with them. We were actually very pleased to also bring in some of the main experts in Lgmd, the clinical experts. So Dr. Johnson, who I believe you heard from earlier today, was part of this effort. Dr. Amato, Dr. Statlin, Dr. Johnson out in Iowa, Dr. Weil, and several, Dr. Mozavar, several others I know I'm already forgetting, but some of these clinicians who perhaps they're your clinicians, or perhaps you're aware of them due to their research or their leadership in clinical studies within Lgmd. But we gathered the groups and we gathered some of the leading clinicians to deliberate on, can we actually obtain ICD-10 codes specific to Lgmd? Now, as you can imagine, what we had to first figure out is Lgmd, as you well know, is not one disease. It's actually, I believe, 34 is the number that's out there right now. There's autosomal dominant, there's autosomal recessive Lgmds, and of course within those categories of Lgmd, there are many subtypes of Lgmds, and each of these have different genetic underpinnings, different etiologies, different onset of symptoms, different progression of symptoms, different experiences. Of course, there is a handful of common experiences, which is why they are collectively defined as Lgmd, but still they're different. They're different in many ways. And as we are expecting you know, not only are there current subtype specific approaches, but there also are, as you well know, gene therapies in the pipeline that are also specific to the specific subtype of LGMD. So we had to figure out, well, what are we going to be able to do to get not just one Lgmd ICD-10 code, because that would be nice. That's better, certainly, than the current situation. But we also had to figure out, well, that's better, but still maybe not good enough. If we're going to be applying for Lgmd ICD-10 codes, why not also apply for codes for the subtypes of Lgmd, as they are all actually different diseases. They are all individual diseases. So as we approached the ICD-10 CM Coordination and Maintenance Committee, this is a government body that is jointly run by the Centers for Medicare and Medicaid Services, as well as the Centers for Disease Control and Prevention. They have this committee that they jointly run. We approached them to basically have this conversation. Can we, in fact, get ICD-10 codes for each individual LGMD? And what they told us was no. Essentially, that was too much granularity too quickly. That was running before we were walking. That was, use whatever metaphor, idiom that you want to use for, that was just too much to start with. That we had to instead do something that was more digestible, I suppose, to start with at the very least, rather than seeking codes for all LGMD subtypes all at the same time, going from 0 to 60 essentially immediately. So what we did instead was, in this letter, actually, that you see here in front of you on the right side of your screen, that was filed with the ICD-10 CM committee on December 4th, 2020, was we proposed codes for the most common LGMDs and the LGMDs with clinical stage treatment development ongoing. So what that meant was we requested codes to use, I know there's several nomenclatures, I know you're all familiar with the new and the old, and probably even older than that for that matter, to use the not immediately new, but the somewhat old at this point nomenclature that's still somewhat oftentimes used. We nominated 2A, 2B, we nominated each of the sarcoglycans, so I believe that's D, E, F. We also nominated 2I and 2L, collagen 6, as well, as we knew these to be the LGMDs that either were the more prevalent LGMDs, or they're, in the case of the sarcoglycans in particular, they're not particularly prevalent, but they do have some ongoing clinical research in gene therapies, especially within the sarcoglycans. And so that's what we presented to the committee. We said, okay, if you're not going to accept all 35 or 34 individual LGMDs actually receiving their own ICD-10 code at this point, perhaps you would accept 10 of them. Those that, again, are the most prevalent, and those that are have ongoing clinical development. And then for all of those LGMDs that aren't in those two categories, there would still be a collective other LGMDs ICD-10 code that would capture them. So still much better than the current other muscular dystrophies code, but still not as precise as going directly to the subtype. So that's what we proposed. And here we are, a year and a half later, actually, perhaps exactly a year and a half later, now that it's June 4th, that we presented at a public meeting in March of 2021, in which we presented, it was actually Dr. Johnson who presented this proposal to the ICD-10 CM committee. And then the ICD-10 CM committee took about a year to deliberate on that proposal. And then in April, they published what they are expecting to finalize in October. And that's an important distinction I'll get to in a second. But these are the codes that the committee is now publishing publicly to say, this is what we're anticipating to actually finalize for an October 2022 implementation. So as you can see, there is a general autosomal dominant LGMD category for an ICD-10 code. And then within autosomal recessive limb-girdles, some of the subtypes are being proposed for their own ICD-10 code. And you could see here, instead of using a specific nomenclature, because as we know, these nomenclatures have changed and maybe they'll change again, who knows. But at the very least, we went straight down to the gene dysfunction, because that's not really changing. At least I don't think anyone's necessarily expecting for the protein name to be changed. But in any case, the LGMDs that, as many of the ones that we nominated, are being proposed for subtype-specific code. That's where you see autosomal recessive Lgmd due to calpain-3 dysfunction, Lgmd due to dysferlin dysfunction. You see several of the sarcoglycans getting their own code, as well as general sarcoglycan dysfunction code, as well as a unspecified sarcoglycan dysfunction code. You see 2L, anoctamin 5 dysfunction being proposed for its own code. And then 2 additional codes, other limb-girdle muscular dystrophy, which means that an individual actually does have their subtype identified. Perhaps they have 2G, or they have 2K or 2M. You know, some of these more rare LGMDs that do indeed have these individuals do actually have their subtype identified, but they don't have one of these more prevalent or LGMDs that are have ongoing treatment development. So that's where they would be coded. They're other LGMD. And then for those who have been clinically diagnosed with LGMD, but perhaps they don't have their subtype identified as of yet. We know many individuals fall within this category. That's where they would be coded as limb-girdle muscular dystrophy unspecified. So they have an LGMD. We don't necessarily know which LGMD, and so instead they would be coded at the G71039 level. So this is what is being proposed right now. So what's next? What's next is this is not technically final yet, because what this committee needs to do, this was in proposed rule format. And as we understand, once it's proposed, it's nearly final. They still reserve the right to change it, but unless something earth-shattering happens, they would expect for the codes that they published as proposed back in April to be finalized this month. So we're actually expecting this month, hopefully in the next couple of weeks, for those codes to be officially finalized. And in that time, we're going to be sending in letters to this Icd-10 CM committee that is jointly run by the CMS and CDC, supporting this proposal, saying at the very least, this is, thank you for nominating, thank you for proposing the codes that are in front of you. Now, I will tell you that's not all we're going to be saying, because if you looked at that list right here, you might see that there's one LGMD subtype that is, at least in our view, and in many others' view for that matter, conspicuously missing, and that's Lgmd2I, which is one of the more prevalent LGMDs. Plus, it has ongoing therapeutic development. There's clinical trials ongoing right now, and we nominated it and we argued for it, and yet for whatever reason, this committee chose not to take our recommendation, chose not to move forward with it. So we're still trying to get to the bottom of that. And as we're trying to get to the bottom of that, we will be mentioning that within our comments that we filed this month of thank you for the codes that you have proposed, but we're still missing some codes here. In particular, Lgmd2I very much deserves their own. Once they're final, and we again expect them to be finalized this month, we're going to be turning to the medical professional community to educate them, because it's not, of course, just the expert clinicians who are probably already aware of this, or maybe even participating in our efforts that need to be educated on the availability of these new codes that would be available in October, again, if they finalize these. There's a lot of other medical professionals out there as well that would need to be aware of these new codes that would be on the books. And so it'll be MDA, it'll be our partnering organizations, it'll be our partnering clinicians, it'll be working with the American Academy of Neurology, the American Academy of Pediatrics, other subspecialties within those two areas as well, to educate the medical community about the availability of these new codes come October of this year. And then for those codes, again, that we have not been successful in getting this far at the very least, and of course Lgmd2I is probably at the front of that list, we'll consider if and how we renominate these codes. And it's not just 2I, there's others as well. Of course, many perhaps on the call today are either a member of other Lgmd subtype communities, or are a loved one or a caregiver or what have you for an Lgmd that you don't see your subtype up there. We'll work to renominate those when the time is right, certainly. But that will be the next steps, as we are also educating the community to use the new codes that are very likely going to be available starting in October. So that's all I have to present to you today. There will be more updates as we continue working on this, as we continue working with our partners at our other organizations that we're partnering with. But at least for this juncture, happy to take any questions on the initiative that we've led thus far.
Thank you, Paul. Quick question, if anybody's interested in being a part of how to get their code for their specific limb-girdle diagnosis, how can they help the MDA advocacy team out?
Yeah, that's a great question. So I know many of you have already helped us out because it was in March of last year when we presented at the public meeting. And then there was a 2-month comment period in which this committee was taking questions or taking feedback from anybody. It was us. We submitted letters, AAN, AAP, the biotech submitted letters, but we also submitted a petition in which I would expect many of you signed that petition, and I really appreciate that. But over, I think, 700 individuals signed that petition, and many of whom, actually all of whom, I believe, were from the Lgmd community, of course. And for a rare disease, that's really remarkable. So first, a big thank you for that. Going forward, ways to help out. At this juncture with the codes that are nearly final, we're probably not going to have an opportunity for advocates to write in on that just because we're 3 steps away from the finish line. However, in the future, if we need your help for a little extra push, or for those codes that we didn't obtain this first time around or almost obtained this first time around, we'll definitely need your help then, because it sounds as if this committee might need a little extra convincing, and that's really where advocate voices can make such a difference. So I would say for codes, both the current ones that we're hoping to get as well as future ones, those will be the opportunities. But I'll just put in a general plug. Of course, we always can use your voice within the advocacy team. I see someone in the chat posted a few links here, and I really appreciate that. The Common Advocate chat or link here. Register with us, and you'll be hearing from us a good amount on how to make air travel more accessible, how to get treatments developed that much quicker and through the FDA that much quicker, how to have better insurance and access to devices and drugs and coverage of specialists and so forth. We do all that kind of work within our MDA advocacy program, and we have opportunities available to you right now, actually, to be sending letters to your congresspersons, to be sending letters into other decision makers on these very important topics. So go to the Take Action Now link down there, become an advocate with us. I would love to have you join us.
A question did come in, Paul. It says, do you foresee that by having codes for specific types of limb girdle, that insurance will reimburse at a higher rate for things such as power chairs, etc.?
Possibly, yeah. I mean, at the very least, the insurers will have a better idea of, okay, so we now know this individual has Lgmd2L, let's say, and we know that power wheelchairs are oftentimes necessary, at this stage of the disease, at this age, whatever it happens to be. They're going to have a much more precise understanding of exactly why this individual may need a power wheelchair or whatever device that it happens to be. And so if they have a more precise understanding of that, they hopefully will be much more willing to, of course, just cover it in the first place, right. But they'll have a better understanding of the utility that power wheelchair will have to the individual. And so they'll have a better understanding for what the appropriate reimbursement rate will be. Obviously, no promises on that, but this very well could facilitate that kind of assessment, that kind of determination by an insurance company.
Well, Paul, thank you so much for being here today. We really appreciate it. Keep up the great work at the Capitol, and thank you so much.
Yeah, thanks, Michelle. Anytime. Thanks, everyone.
Go back and share my screen really quickly. The Lgmd community will be leading an externally led patient-focused drug development meeting on September 23rd, 2022. This important monumental effort will give individuals diagnosed with limb-girdle muscular dystrophy types 2A, 2C, 2D, 2E, 2F, and 2I an opportunity to share with the FDA and other stakeholders about the experiences and challenges of living with limb-girdle. I'd like to share a short video with you about the event.
An externally led, patient-focused drug development meeting for 6 limb-girdle subtypes will be held on September 23rd and will focus on the 4 psychoglycanopathies: Lgmd 2C, R5, 2D, R3, 2E, R4, 2F, R6, as well as Lgmd 2A, R1, and 2I, R9. Your involvement is critical to the success of this vital initiative for our limb-girdle community. This EL-PFDD meeting will give the FDA and other key stakeholders an opportunity to hear directly from those of you living with LGMD, your family, and caregivers. Your input will provide critical context for the FDA regulatory decision-making process for new drugs and treatment. This virtual meeting will include live speakers, pre-recorded panelists, and throughout the day, live polling and discussion forums featuring you, our viewing audience. The morning session will focus on subtype symptoms, their health effects, and the toll these 6 forms of LGMD take on your daily living. The afternoon session will highlight our community's perspectives on currently available and future treatments and communicate our tolerance to risk. Afterwards, a Voice of the Patient meeting summary report will be issued. It will serve as an educational reference document for the FDA, medical product developers, healthcare providers, federal partners, and the LGMD community. We encourage individuals living with these 6 LGMD subtypes and their caregivers to join our team. So please register at thespeakfoundation.com/PFDD to keep apprised of the planning process and to learn how your voice will make a difference on September 23rd.
Following the symposium, you will be receiving a handout with information about this event. Pull up my screen. I would like to thank our guest presenters from today, Dr. Nick Johnson, Mary Jane Voss, Caitlin Payne, Amber Ward, and Paul Melmeyer. We appreciate your time and expertise. Thank you for being here today. We would also like to thank our Limb-Girdle Symposium supporter, Sarepta. We would love to hear your comments about MDA's Limb-Girdle Muscular Dystrophy Symposium. If you have a smartphone, open your camera and point it at the QR code on the screen. A web page will pop up with a short survey on today's symposium. If you do not have a smartphone, once the symposium is over, a screen will pop up with the survey as well. Everyone who fills out the survey to completion will be included in a raffle for a Visa gift card. For additional questions, please email them to mdaengage@mdausa.org, and we will follow back up with you. If you are new to MDA through this program and are diagnosed with a neuromuscular disease under MDA's umbrella, or are a loved one of someone who is diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. This will keep you up to date on the latest information and education to help keep families informed in the neuromuscular community. I would also like to say a huge shout out to our MDA tech in the background chatting and all of the resources and links to everyone, to all of our things that we heard today. So thank you so much for being here with me today. I really appreciate it. This concludes the 2022 MDA Engage Limb-Girdle Muscular Dystrophy Symposium. Thank you very much for attending and have a great rest of your day.